All right, it looks like we're getting started. I know people are starting to join here, and we will give it another moment or two. I just want to welcome everybody. My name is Melody Turk. I'm the Learning Experience Director for Urgent Care Association. And as I said, we'll give it one more moment, but just for those of you that are logging on to make sure you're at the right webinar. The name of this webinar is COVID Now, Future Predictions and the CDC Position on Testing. So we will have our own Dr. Bhogal from our College of Urgent Care Medicine moderating today with some special speakers from the CDC. So if you're on the wrong webinar, please hang up. If you're on the right one, definitely stay and join us for this conversation. You'll see a Q&A module probably at the bottom of your screen where you can input questions during the webinar, and we will try to get to those either in the middle of the webinar or at the end of the webinar. And of course, if you can't find that, please go ahead and use your chat feature, and Dr. Bhogal will try to address those as we go along. Of course, we will try to get through all the information that the CDC would like to share with us today. So those questions may have to wait till the end, and we'll post another way for you to get questions to us. We will absolutely follow up after the webinar if we weren't able to get to all of them. So let's see. I know people are still joining. It looks like we have a good amount here. Dr. Bhogal, are you ready? Is there anything I forgot that I need to remind people of?
No, I think, Melody, that's great. I guess we can go ahead and begin so that we respect everyone's time on this call as well, both the participants and the members and so on and so forth. Right. So hello, everyone. Thank you so much for joining this webinar. We truly appreciate it. Busy times and, just taking an hour away from everyone. We truly respect that. And again, thank you so much. I would like to introduce our first speaker for today. Dr. McClung is currently serving as the Chief Medical Officer for CDC's COVID-19 Response. Dr. McClung completed his medical school at University of Texas Southern-Western. I'm sorry, I'm in the Maryland area, so I apologize for that. In the Southern-Western Medical School. And his internal medicine residency and chief residency at Emory University School of Medicine. He's a graduate of the Epidemic Intelligence Service Fellowship Program at the CDC. And when he's not working on the CDC 19 response, he's the lead of the HIV outbreak response team in CDC's Division of HIV Prevention. So I think we have the perfect speaker for the first part of our webinar today. And Dr. McClung would be updating us on the status of the Omicron virus. So Dr. McClung, you can take it away.
Thank you very much. Making sure you can hear me okay? All right. It's great to be with you all today. I know that at this point in time, almost all of you have heard of Omicron. You've probably been seeing Omicron, and you may have even been infected with Omicron yourself. And for this talk, I just want to focus on a few of the scientific details that we've learned about Omicron and focus on the 4 questions that you see on the screen here about transmissibility of Omicron, the severity, the protection afforded by vaccines, and the therapeutics that are available to treat Omicron infection. Next slide. So let's look at the transmissibility of Omicron first. So US COVID-19 cases have rapidly increased since the first Omicron case was reported on December 1st. Daily and weekly case counts have so far exceeded anything that we've seen in prior waves of the pandemic. As you can see, this red line shows the 7-day rolling average of cases. And to look at the scale of this, we're talking about more than 500,000 cases reported in the US each week for the past several weeks. Good news is that overall, it looks like we've passed the peak of the surge, but we're still way above levels that we were seeing before Omicron entered the picture. And while we're hopeful that this will be a steep decline on the other side, we really don't have any guarantees that it will look like that just yet. Next slide. Since that first case was reported on December 1st, Omicron has very rapidly taken over as the dominant variant in the United States. On this figure, you can see that each bar is a week in time, and the orange, which represents the Delta variant, was quickly replaced by the purple, which is Omicron, within just a few weeks of first appearing on the scene. Well, how is it that a new variant could arrive and take over so quickly? And the Delta variant, as a reminder, was not a weak version of the virus at all. It too had previously displaced other variants to gain dominance. Next slide. Next slide. There we go. Oh, one back. And one more. Thank you. The answer to that question about Omicron's advantage is that it has an unusually large number of mutations compared to previous variants. On this slide, the row at the top shows the original arrangement of the SARS-CoV-2 spike protein. And as you look at the three rows below that, you can see there's a handful of mutations for alpha, for beta, and for delta. But when you get to Omicron on the bottom, that number really jumps up. And this combination of mutations helps Omicron to be transmitted more easily and to more easily escape the innate and antibody-mediated immune response. Next slide. So as a result, we've seen Omicron causing higher rates of infections among contacts of cases. So this study from Denmark looked at transmission between household members and found that while secondary attack rates within the house were similar for Omicron and Delta among unvaccinated people, when you look at fully vaccinated and boosted individuals, there was a much higher secondary attack rate for Omicron compared to Delta. So that's 32% of those household contacts versus 19 for Delta for fully vaccinated people, and 25% versus 11% for those who had a booster. I do want to point out, though, that those who had a booster did have a lower secondary attack rate overall, and it shows just one of the benefits of a booster over a primary vaccine series alone. Next slide. We've also seen that the rate of reinfections among unvaccinated people has risen very rapidly during the time of Omicron. This figure from the UK shows first infections by week as the red line, and the reinfection rate is shown as the blue line. So that if you track with that blue line, the reinfection rate is about 1 per 1,000 first infections for months and months throughout the pandemic. But once the Omicron period begins, on the right side of the slide, you see the reinfection rate jumps up to close to 15 per 1,000 first infections. Other studies that have looked at reinfection have estimated that the risk of reinfection from Omicron is anywhere from 3 to 5 times higher than it was for the Delta variant. Next slide. Finally, besides the higher rate of secondary transmission and higher rates of reinfection, another reason for the incredibly fast rise in the number of new cases is that the incubation period for Omicron appears to be shorter than for prior variants. This figure shows the date of symptom onset for several dozen people who were infected at a Christmas party in Norway early on in the time of Omicron. That vertical line, small vertical line you see shows the date of the party, and you can see that symptoms begin very soon after that party. And the authors calculated the incubation period from exposure to symptom onset and found that the median was 3 days, which is pretty short compared to previous reports of Delta, which was around 4.3 days, or even early variants at about 5 days. And this allows transmission to move more quickly from person to person to person. Next slide. So case counts have risen higher and faster with Omicron, but what about severity? What do we know about severe disease and death? First, here are hospitalizations in the United States. The good news here is that compared with prior peaks, the number of daily new hospital admissions has not risen as sharply as we have seen with case counts. And it even appears to be beginning to come down again. The bad news, though, is that even still, we've been averaging upwards of 20,000 hospitalizations during this peak, which is higher than prior waves, and it's put a lot of stress on healthcare systems and communities across the country. Next slide. Digging a little deeper, this analysis of data from Kaiser Permanente found that when you compare outcomes of Omicron cases to Delta cases, for Omicron, the risk of hospitalization was about half. The risk of ICU admission was 74% lower, and the risk of death was reduced by 91% when compared to Delta. Also, interestingly, for those who were admitted to the hospital with Omicron, the length of stay was 70% shorter, or about 3.4 days shorter. And last, and importantly, the analysis found that disease severity was lower for Omicron regardless of vaccination status. Next slide. In South Africa, where the Omicron variant was first widely detected, researchers found that during Omicron, only 5% of their cases were admitted to the hospital, which was much lower than for Delta or Beta. And for those who were admitted, the requirement for oxygen was much lower, and fewer people met criteria for severe disease. Fewer people ended up dying as well, just 6% of those admitted to the hospital compared to 24% for Delta and Beta. And why is that? Is it because Omicron is truly milder, or is it related to the fact that people had some amount of protection from vaccination or prior infection? Let's go to the next slide. When investigators in South Africa looked at this question, they found that while overall the risk of hospitalization or death was reduced by about half during Omicron compared to Delta, when they were able to account for vaccination or prior infection, the risk of hospitalization and death was only 28% lower. And so this suggests that it's a combination of lower intrinsic virulence of Omicron and some level of protection from severe disease provided by vaccination or prior infection. Next slide. Despite all that, given the sheer number of new cases due to Omicron over the past few weeks in the United States, we are seeing a rise in daily reported deaths, now up to above 2,000 per day and climbing. And these deaths, which lag behind cases and hospitalizations by a couple of weeks, are a reminder that while Omicron might be milder than prior variants, it's not truly mild, especially not for the hundreds of thousands who do require hospitalization during this period, or for the tens of thousands who will end up passing away. Next slide. And before we move on, I want to highlight one more interesting detail about the clinical presentation of Omicron. In this UK study, looking at predominantly mild infections that were diagnosed in the community, they plotted the frequency with which individual symptoms were reported. And the trend that they saw in the Omicron period is what I want to highlight. So on the left, this chart shows a separate line for cough, fever, loss of smell, and loss of taste. And if you look at the blue and purple lines, they drop like a rock starting in December. Those are for loss of smell and loss of taste. And they fell from above 40% down to less than 15% very quickly around the time that Omicron emerged. And on the right, while most of the symptoms you see there took a slight downturn in December and January, sore throat went in the other direction. That's the pink line. It increased from just over 40% to about 60%. It's an interesting shift. I don't have a totally satisfactory explanation for it, but I wanted to share it with you as you care for people each day on the front lines. And I'm wondering if maybe some of you have also noted that trend in symptoms of patients that you've been seeing. Next slide. Up next is how well do our vaccines protect against infection and hospitalization due to Omicron? So data from the UK show that Pfizer vaccine effectiveness is lower for infections due to Omicron compared to Delta. In this figure, the black squares represent vaccine effectiveness for Delta and the gray circles are for Omicron. So you can see that for each time point on the x-axis, which is the number of weeks after vaccination, Omicron vaccine effectiveness is lower than for Delta. The difference is especially large for those who completed a 2-dose series weeks or even months ago. You'll see that after about 15 weeks, VE drops to below 20% for Omicron. However, of Pfizer or Moderna booster, restores protection from infection back up to initial levels. That's in the second and third section on the slide. As you can see, though, there is some waning from the booster that can again be seen starting a month or so after. Next slide. Fortunately, protection against hospitalization is higher than for infection. So this US study looked at vaccine effectiveness for Omicron and for Delta against emergency department or urgent care visits, as well as against hospitalization. During Omicron, a 2-dose primary series was just 52% effective against an ED or urgent care visit within the first 6 months after vaccination and dropped to 38% beyond 6 months. For hospitalization, it was better, 81% in the first 6 months, but down to 57% after that. However, for those who received a booster, this improved substantially, up to 82% for emergency department or urgent care visits and up to 90% against hospitalization. Next slide. And last, from the UK, a bit of good news about this protection from hospitalization is that if you look at that far right column, you'll see that while 2-dose VE was below 50% after 25 weeks of that 2-dose series, when you add a booster, it bumped it up to 92%, and it stayed relatively high, a little small decline, but relatively high after 10 weeks and beyond after that booster. This is another piece of evidence underscoring the benefits of adding a booster. Next slide. All right, before I wrap up, I want to briefly touch on outpatient therapeutic options that are available for COVID-19, some of which were just authorized for use in the past couple of months. The NIH COVID-19 treatment guidelines panel currently recommends 4 options for high-risk, non-hospitalized people with mild to moderate COVID-19 who are at a high risk of progressing to severe disease. This includes one monoclonal antibody, which is sotrovimab, and 3 antivirals, remdesivir, which we've had for a while, but is now available outpatient, Paxlovid, and molnupiravir. Next slide. A couple of things to highlight about these drugs. First, none of them are authorized for use in people less than 12 years old, and molnupiravir is just for people who are 18 and older. Second, all of them have a specific window within which they must be started. So for the oral antivirals, Paxlovid and molnupiravir specifically, that's a 5-day window, which begins at the time that symptoms begin. It's a little bit longer for remdesivir and sotrovimab, but it's important for people who do test positive and could benefit from these drugs to promptly seek care and be able to be prescribed and receive these treatments. Third, I want to point out that supply is currently a challenge for some of these drugs, especially for Paxlovid and for sotrovimab. This is expected to improve in the coming months, something that we're working hard at across the US government right now. Next slide. So speaking of the government, this is a partnership between agencies to make these drugs possible here in the United States. This slide from FDA highlights links where you can find details of the authorization for these various drugs, as well as a link to a COVID-19 therapeutics locator, which allows you to see where these treatments are being distributed and what their current inventory looks like. Next slide. Our partners within the Department of Health and Human Services have also developed a guide for clinical implementation of COVID-19 therapeutics. And this contact information I wanted to share with you for anyone who is hoping to learn more about what this could look like. Next slide. They've also set up a series of calls that are open to various stakeholder groups, some of which are listed here. And again, if you would like to be linked to these calls or have other questions about therapeutics, I encourage you to reach out to COVID-19 therapeutics at hhs.gov. Next slide. So to close, Our best understanding of Omicron so far is that Omicron is more transmissible than prior variants, but it appears to have somewhat reduced severity. We've seen that currently authorized vaccines provide less protection against Omicron infection compared to prior strains, but they still provide protection against hospitalization and death. Vaccination with a primary series and a booster when eligible is a really important part of reducing this risk. Finally, it's important to remember that the best way to reduce infections, hospitalizations, and deaths due to Omicron is to continue to use a combination of strategies. And that includes vaccination, treatment, as well as masking, quarantine and isolation, and physical distancing. And these activities combined give us our best shot to decrease transmission and prevent unnecessary hospitalizations and deaths. Thank you very much. And I will hand it back to you.
Thank you, Dr. McClung. This was some really great information. We already have some great questions coming in the Q&A and the chat boxes. And for our members, please keep posting these questions. They're all very relevant to the clinical practice. What our plan is that we will go through both the presentations and then dive deep into each of these questions that you are posting. So please don't feel we're ignoring them. It's just that we're going to finish the presentations and then take a deeper dive at the Q&A and start a discussion on that. So our next speaker, I would like to introduce Dr. Salerno. He is the lead for the expansion of screening and diagnostics task force for CDC's COVID-19 response. He's also served as the co-lead for the laboratory and testing task force for CDC's COVID-19 response. His permanent position is actually the director of CDC's Division of Laboratory Systems. He is the lead CDC official for the Federal Tri-Agency Clinical Laboratory Improvement Amendments, or the CLIA program, and the designated federal official of the U.S. Clinical Laboratory Improvement Advisory Committee. He represents CDC on the Tri-Agency Task Force for Emergency Diagnostics and the Federal Interagency Working Group on Improving Diagnostic Safety and Quality in Healthcare. Welcome, Dr. Salerno.
Thank you so much, Dr. Bhogal, and thank you to Llewellyn and everyone else part of the Urgent Care Association. Really grateful to be asked to be here today, and hopefully this will prove useful for you. So I'm going to focus on the testing piece and try to be as clear as possible. I realize this is a complicated topic, but I'll give it my best shot. So next slide, please. Okay, so in general, we think of the tests that are authorized for detecting SARS-CoV-2, which is the virus that causes COVID-19, in three large categories: laboratory-based tests, point-of-care administered tests, and what we call self-tests, or over-the-counter or at-home tests. And these three categories of tests vary considerably from a number of perspectives. When we talk about laboratory-based tests, these are mostly nucleic acid amplification tests, or what we call NATs, that detect viral ribonucleic acid, or RNA. Those tests are complex to operate, long turnaround time, obviously, because it includes transportation to a laboratory, and they tend to be more expensive. They are, however, very high sensitivity and high specificity, so they're very reliable tests. Although one problem, which I'm sure you're aware of, is that these tests also are so sensitive that they often can detect remnant RNA well after the infectious period. Laboratory-based tests require a very specific CLIA certificate of accreditation, or a certificate of compliance. And so there's a lot of government oversight of laboratory-based diagnostic testing. Point-of-care tests can be either nucleic acid amplification tests, although these are not RT-PCR. So when people say RT-PCR, those are laboratory-based tests. Those are complex tests that are done in a laboratory. There are, however, nucleic acid amplification tests, such as LAMP tests, or loop isolated amphithemal tests that are nucleic acid amplification tests that can be performed at the point of care. But most of the point of care tests that are available to detect SARS-CoV-2 are antigen tests. Point of care tests are easier to use. They have faster turnaround time, and the cost is lower than a laboratory test. Their sensitivity is moderate, so not quite as high as a laboratory-based test, but their specificity is quite high. So the positive results are still very reliable for point of care tests, but a negative result is a little bit less reliable for a point of care test than a laboratory test. And more recently, we now have self-tests. I'm sure you're well aware of that. Hopefully you've all ordered your free self-tests from the government online already. I just received my 4 tests in the mail late last night. Very exciting. These are mostly antigen tests. They're very easy to use. The turnaround time is fast and they're very inexpensive. But the sensitivity of these tests is really very moderate, but the specificity remains very good. There are no clear requirements for at-home testing. And I did miss or skipped over the fact that for point of care testing, there still is CLIA regulations that apply, but the CLIA certificate of waiver can be used for point of care testing. I'm sure all of you in the Urgent Care Association are well aware of the CLIA certificate of waiver process. Next slide, please. Okay, so the question we seem to be asked all the time, perhaps most frequently now, is when to test for COVID-19. And we think of the answer to this question really in 3 specific areas or buckets. If you are symptomatic, regardless of anything else, we recommend that you test immediately with any viral test. Right? A viral test could be either a nucleic acid amplification test or an antigen test. But if you're symptomatic, test right away. And that's especially true for, or necessary for Omicron, as Paul just explained. The incubation period is, we believe, shorter. And so testing immediately upon symptom onset is very important. Next category of when to test is if you've had a close contact to someone with COVID-19, then we recommend that you test and you're asymptomatic, right? Then test at least 5 days after that contact. We do not want people testing immediately after close contact or exposure, because it does take some time before the virus has gotten to a place where it is easily detectable by the tests that are available. And then third is if you plan to attend a gathering with other people and you're asymptomatic, but you are concerned about potentially causing a transmission, and you recognize that there's a good chance of asymptomatic transmission, or that is a relevant piece of what we're seeing today and have seen throughout the pandemic, we would recommend that you test immediately before or as close in time to that event as possible. And this kind of preemptive or protective testing is really important, especially before gathering with other individuals who may be at risk of severe disease, such as the elderly, the immunocompromised, or unvaccinated people, or children who can't get vaccinated. Next slide, please. What tests should be used? Okay, this is a huge challenge for all of us, especially during this pandemic, because there have been so many different tests authorized by the FDA, both in the nucleic acid amplification category as well as antigen tests. I'm not even talking about antibody tests here today, because those are not used to identify infection. But even so, there are so many tests on the market that it's really difficult for any of us to keep track of the performance characteristics of all of these tests. However, what we can say is that laboratory-based tests do have higher sensitivity than point of care or self-tests. And we also can say that NATs, or nucleic acid amplification tests, have higher sensitivity than antigen tests. So if you're really concerned about avoiding a false negative, a negative test result that actually is not negative, right? Because some of these tests are low sensitivity, which means that there's a possibility that they could indicate negative in a person or for a person who actually has infection. And if that is a primary concern for you as a healthcare provider, and that should be a concern when you're testing those who are at highest risk for severe disease and can most benefit from possible treatment, we recommend that you select a laboratory-based NAT if available, or a point of care based NAT, because the sensitivity is better than the antigen test. And just in case, just for information, if those at highest risk for severe disease, especially if they're symptomatic, are those with underlying medical conditions, the immunocompromised, the elderly, and the unvaccinated. Next slide, please. Okay, so another frequent question that we are receiving at CDC is, what is the effectiveness of antigen tests against the Omicron variant? And honestly, I'm not sure that the science is crystal clear yet on this topic. You may be aware that in late December, the Food and Drug Administration put a notification on its website that said that early data suggests that antigen tests do detect the Omicron variant, but may have reduced sensitivity. About a week later, there was this particular article was published that used a relatively small amount of data, but nevertheless, it was a really interesting study that showed that many of the Omicron cases in their study were infectious for several days before they could be detected by rapid antigen tests, and that there was this where they could be detected early on by a nucleic acid amplification test, but it took a few days of the infection evolving in the individuals before the antigen tests gave that positive indication. So that article really helped or reinforced the position that FDA published the week earlier about reduced sensitivity of antigen tests against Omicron. However, just recently, January 19th, another article came out which really challenged that position and showed that the Binax Now, which is one of many antigen tests that are authorized and one of the, frankly, the most popular, that test detected Omicron with a sensitivity similar to that observed for prior variants. And so that article really argued that there wasn't much of a difference at all between Binax Now detecting Omicron versus being able to detect Delta or other earlier variants. So there's not a definitive answer to this question. It is something that the government, as well as the academic community, are paying close attention to, continuing to study, and I'm sure there will be more data that comes out on this particular question. Next slide, please. Okay, so let me go through what to do with test results. So the positive test result is much easier. And that's because we feel very good, regardless of test type, that a positive test result means that, that the virus was detected and that person was very likely to have an infection. And we strongly believe specificity is high. A lot of studies have been done that regardless of test type, laboratory-based test, point of care-based tests, and self-tests, that those positive results are reliable. That doesn't mean that there's no chance of a false positive. I'm not suggesting that. But especially at times like now, where the prevalence of disease is quite high, the likelihood of a false positive result is very low across the board for these tests. So those positive tests, especially now, those positive test results are very reliable. And so we want anyone who gets a positive test result, regardless of test, to isolate, to inform their close contacts, be cautious about symptoms worsening, especially if they have any emergency warning signs. But now, especially that, as Paul was saying, we're beginning to have more availability for treatments. It's particularly important for those with underlying medical conditions that increases their risk from COVID-19 to seek care as quickly as possible if they have a positive test result. Next slide, please. Okay, so negative test results are a little bit more difficult. A negative test result, regardless of test type, means is that the virus was not detected in the specimen. And it likely means that there's a lower risk of transmitting the disease to others. Not necessarily no risk, definitely not no risk of transmission, but we say that there is a lower risk of transmitting the disease to others if you have a negative test result. But it's really important to stress to patients that a negative test result does not rule out infection, and serial testing needs to be considered. Next slide, please. Okay, so I'm going to start with a negative test result from an asymptomatic patient. What do we do? If this patient has no close contact to someone with COVID-19, they do not need to quarantine or isolate. And their vaccination status really doesn't matter in that particular scenario. If the patient is up to date on their vaccinations, regardless of any exposure or contact to COVID-19, that asymptomatic negative test result indicates that they do not need to quarantine or isolate. However, if you have an asymptomatic negative test result and you have had close contact to someone with COVID-19 and you are not up to date on your vaccinations, then CDC recommends that you quarantine. Exception there, you see there's a little asterisk, is that quarantine is not necessary if positive by viral test in the past 90 days. I will say that the Omicron variant is compelling us in the scientific community to really study the 90-day test exemption and quarantine policies. But that, for the time being, our policy and our recommendations remain unchanged, so that quarantine wouldn't be necessary if you have a positive viral test in the past 90 days, even if you've had close contact and you're not up to date with vaccines. Next slide, please. Okay, so this is the sort of the most complicated scenario. And that is you have a person who's symptomatic, but has a negative test result. And now the test that you use or that was used makes a difference, right? So that if you have a symptomatic patient and a negative NAT result, a nucleic acid amplification test, then I think it's important to consider alternative diagnoses. Could it be the flu? And to instruct that patient to contact their healthcare provider if their symptoms worsen, and to avoid contact with others until symptoms are clear. If they've had close contact with someone with COVID-19 and they're not up to date on their vaccinations, then our recommendation is that they should quarantine even if they've had a negative test result. And that's because they're symptomatic and they've had close contact. Okay, For the negative antigen result, so if you've used a point of care antigen test, or they've used a self-test antigen test and they have a negative result, then this is where we would recommend that you really think through pretest probability. And a high pretest probability would be a scenario where there is high community transmission or close contact or suspected exposure to a person with COVID-19. And if you believe there's high pretest probability, it's important that that negative antigen test result be either confirmed with a NAT test, or that they use serial antigen testing strategy. I'll talk about that, both of these in a moment. So for a confirmatory test using a NAT, we would recommend that confirmatory test take place as soon as possible after the first antigen test. However, if you don't have easy access to a NAT confirmatory test, serial antigen testing 1 to 2 days after the first antigen test is an alternative. Next slide, please. Okay, so let's talk a little bit about confirmatory testing. So in our minds, when we say confirmatory testing, it's really using a nucleic acid amplification test to confirm an antigen, symptomatic antigen negative test result. Okay. So in other words, we would not say, and hopefully we don't say, that an antigen test can confirm another antigen test. Only a NAT test can confirm a symptomatic antigen negative. So if that confirmatory test by NAT is negative, so you have an antigen negative followed by a NAT negative, then we would recommend you can consider alternative diagnoses. And I've said this before, have them call their healthcare provider if their symptoms worsen, avoid contact until their symptoms have cleared up. And if they have had close contact to COVID-19 and are not up to date on vaccination, then we would recommend that they quarantine. However, if you have a symptomatic antigen negative test followed by a NAT positive test, then that NAT test, because it's more sensitive, should be the test that you rely on. And in that case, that would be a positive case, and they should follow CDC's guidance for isolation and follow all those other things that we talked about on slide 4, which was what do you do with a positive result. For self-tests, we do not recommend or require confirmatory testing for positive results, but for negative results, because those are low sensitivity tests, it may be necessary to either get a confirmatory test or better, unless you're someone at risk, just to rely on serial testing. Next slide, please. So let's talk a little bit about serial testing. Serial testing is when we use the same type of test, but in a series, spread out over 1 to 2 days, or perhaps longer. And again, when you're doing serial testing, it's very important to read the manufacturer's instructions and to understand how that test has been authorized for serial testing. So a symptomatic antigen negative followed by another antigen test would be serial testing. And so if you receive 2 antigen results spread out over 1 to 2 days, or based on the manufacturer's instructions, at that point, again, but this person remains symptomatic, then obviously you'd consider alternative diagnoses. If an antigen negative is followed by an antigen positive, then you should treat that person as positive, and they should follow CDC's guidance for isolation. Another advantage of serial testing is it can lower the risk of transmission regardless of symptom or vaccination status. And there have been studies to show that multiple antigen tests used in series collectively increase the selectivity I'm sorry, the sensitivity of the antigen tests. And so that by using them in series, multiple negatives can give you more confidence that you're not infected by SARS-CoV-2. Next slide, please. Okay, so this is just a little bit of advertising for the US government. Hopefully everybody knows that covidtest.gov now provides 4 free tests to every household. It's very easy to use. It's the most popular government website in the history of government websites. So lots of information there, and hopefully the government has made it very accessible even for those people with disabilities who need support in placing an order. Next slide, please. And then I think this slide, this slide is just a list of various references, guidance pages that we have at CDC on all these various testing related topics. So I think that does it for me. Thank you.
Thank you so much, Dr. Salerno. This was some really great information. We're already getting comments in the chat that we be able to share all this information and or the slides. Llewellyn, Laurel, for our audience, how will we be sharing all this information so that they can review at a later time as well?
We'll be sending out a link within about 24 hours, and then we'll have an email at the end where they can send any additional questions that we didn't get to. That'll be in the email as well. So all attendees will get that link to the recording.
Perfect. Thank you so much. Appreciate it. Okay. So in the time remaining, I think there's a lot of questions that came along, a lot of really good clinical questions. So I guess we'll take it from the top in the order that they came in. So the first question that came in was, what do we know about the level of protection that an infection with Omicron confers?
I can take that. Thanks for the question. So it's a good one. We all would like to know, but it's a little too soon. So we do not have a good understanding of that just yet. A lot of people who were infected with Omicron have only had a few weeks or a couple of months at most since their infection. So it's hard to know how long, if immunity will last or exactly what that will look like. We're monitoring that at CDC. We have a number of studies that will be following people out to further time points to be able to get some more insight on that topic. But I will say that our understanding from prior variants is that that immunity from prior infection is good. It is good at preventing future infection as well as hospitalization and death, and that can last for up to 6 months or more. And so we don't have any reason specifically to suspect that will not be the case for Omicron.
Thank you, Dr. McClung. So there's quite a few questions about home testing. So I'll take them again in the order that they came through. So the first is, are the case rates of COVID-19 underreported due to the availability of at-home testing now?
Do you want that one, Paul, or do you want me to do it?
Oh, I can jump in and then feel free to add. I think there are a number of factors that contribute to underreporting. I think the case counts that we see are not this necessarily representing the full extent of transmission in the United States. And just a couple of factors include people who become sick and don't ever test, maybe by choice. They were a close contact of someone who was ill and they got an illness that was very similar and they figured it was COVID-19. And so they stayed home until they felt better without needing to confirm it. Certainly there's times when test availability is low. And so people are not testing because they haven't been able to locate a test that would then go on to be reported. And then, yes, I think certainly we encourage people to report home tests or self-tests, but that is not something that always happens. And so as that has become a bigger and bigger part of the response, I do think more of those infections have probably not been included in the case counts. Ren, I don't know if you have any other thoughts.
The only other thought I would add is that, our estimate is that testing overall in terms of number of laboratory tests that are conducted, point of care tests that are performed, and a number of self-tests that are either on the market or have been purchased is almost tenfold more today than it was a year ago. So there are just so many more tests available, and many more people are getting tested now than a year ago. And so I think we can, while it's true that we are not capturing every single self-test result, I think it's also true that a year ago and probably throughout the pandemic, we have not been capturing every single case. And so our surveillance efforts have always been a broad estimate of what is happening in the pandemic. But honestly, we feel very good about the amount of data that we receive across the board from laboratory testing and point of care testing to make estimates about what we're seeing from a surveillance point of view.
Got it. Thank you. Another interesting question about testing. It relates to the role of antibody titers in delaying the booster. And is it clinically appropriate to delay the booster for 90 days from an infection date? So I guess it's a combination of antibody testing, its relevance, its meaningfulness, and then how it relates, and if there's any clinical evidence of delaying the booster for 90 days after an actual infection.
Yeah, I'm happy to start from the vaccine recommendation side, and then Ren, feel free to jump in, especially if you have any thoughts on the use of antibody tests in general. But we do address in our vaccine guidelines specifically that viral testing to look for prior infection or serologic testing is not recommended for making decisions about vaccination. We really don't have the evidence to say what antibody titer threshold should be used, or to even establish what the test should be. There are a lot of antibody tests out there to determine what should reliably be considered to be a marker of past infection. There are data to suggest that it is safe to give the vaccine to people with evidence of a prior infection, and that it is appropriate to do so as early as right after they have finished their illness. And so at this point in time, we don't have a specific time period for deferring that, and would not necessarily encourage people to seek out antibody tests to further refine that period.
Got it. Thank you. Yeah, the antibiotic question comes up more and more now, especially in relation to, hey, if someone does get antibody testing done after getting vaccinated, after having Omicron, let's say, and the antibodies are positive, what does that mean, right? Are they kind of free to, be maskless and whatnot? So I think this is more going to be an important question that's going to keep coming up again and again. Another question that we had was in relation to the treatment. So for consideration of treatment, is a point of care antigen test with reflex to lab nucleic acid amplification test, if the point of care test was negative, appropriate? So that's the first part of the question. So basically your antigen test was negative, the nucleic acid amplification test was negative, and how do we consider it for treatment? And the second part is, many patients at high risk present on second or third day of symptoms, and referral lab tests have a 2 to 3 day turnaround time. So how do we manage treatment considerations in that situation?
So I'll put on my clinician hat for a second on this one and say, to my knowledge, the NIH treatment guidelines that are responsible for really laying out what you should do for patients who would benefit from treatment do not specify what tests should be used or how it must be confirmed in order to sort of give you the green light to start treatment. If folks are having a hard time getting access to treatment because specific documentation is being required of you, I'd love to know about that, and we can take that back and sort through that. So please do, give us that feedback now. But what I would say for clinicians out there is that if you have a patient who would benefit from treatment you think that their clinical picture, as well as their, maybe they had an exposure, it really looks like COVID-19, and you have a window of opportunity to link them to treatment, I would not delay that. And I know that could come up when people ask questions about, well, could you give me treatment? I had a positive home test should I confirm that home test when I have them in front of me in the clinic? Or what combination of tests do I need to do in order to proceed? We know that there are delays with NAT testing. Sometimes if you don't have point of care options, don't delay, do what's best for your patient. And if you're having difficulties doing that, we'd like to know so that we can feed that back for helping to streamline things. We know that this window of time can be kind of short.
Got it. Yeah, and a follow up to this, we've got two questions about the same thing about, if a patient has tested positive in a home test, do the clinicians, physicians need to see the test result or require a witness test to prescribe, Paxlovid, which is the oral version, or refer for IV therapy? And there's obviously shortage of the drugs in the market as well. So I guess that's a in question that we are kind of anticipating in urgent care will come up more and more. Patient says, yeah, I tested positive at home, where's my prescription for the Paxlovid? So
again, I would say be the advocate for your patient there. And I am not aware of a sort of red tape that would prevent you from doing that. Again, I am ready to be corrected if y'all are struggling with that specific issue. But no, there's not otherwise specific guidance for a sequence of tests that needs to happen.
got it. So more of a clinical decision making at this point in time, kind of relying maybe on what the patient is saying and then kind of going from there.
And I should add that that these symptoms we know are have overlap with other disease processes. So if there's some question about this, obviously consider influenza, consider other illnesses that may be circulating. Rule those things out if you can. Particularly if you have question marks in your mind about if this is really COVID-19. But once you've done that, I think clinical judgment will still need to sit with the clinician who's got the patient in front of them.
Yeah, perfect. These are great answers. I think very helpful for everyone as a clinician on this call. One of the other questions was, how do you explain how the nucleic acid amplification test can detect residual spike protein weeks after an infection when the virus is dead and should be gone? The protein should easily be destroyed and or the mucus removed, or is this spike just like a cactus spike and stuck in the cell receptor? I think that's the answer, I guess.
Yeah, I am not a laboratorian, but I will tell you that, and Ren, please jump in, but I think the question of what we call sort of shedding or this long-term positivity with a NAT test, it has to do with the ability to pick up fragments, not necessarily just the spike protein, but fragments of the virus that have accumulated in cells in potentially various parts of the body as a part of the immune response during that infection. And so the clearance of that is not straightforward. It is very unusual to be able to detect any live virus that's able to replicate after about 10 days from after symptom onset. But those remnants can sort of continue. I know that may be disturbing when you think about it. I have not heard the cactus spike idea, reference with regard to the spike protein, but I like that. And we do see that can linger for weeks after infection. So it's may not be a totally satisfactory answer. It's a little bit hard to conceptualize the way that, and it relates to the way the tests themselves work, but hopefully provides a little bit of light.
Yeah, thank you so much. Yeah, one of the scenarios that I actually saw yesterday at our clinic was this patient who had tested positive for COVID-19 in early December. Symptoms completely resolved after that and came in with a new set of symptoms for the last 3-4 days now. And the question that the patient asked me was, is this a reinfection? And I think that's one of the, I mean, the test came back positive, lo and behold. So, now we don't know whether it's positive because of the previous infection or the new one. And I think that's one of the clinical questions that is coming up pretty fairly again and again as well now. Now that people are getting, they recover and they get a new set of symptoms within that time, quasi 90-day time frame. I think that's a tough question clinically to answer for us as well. So I don't know whether you have any comments on that.
So Ren and I and others have actually been discussing these types of scenarios recently. Maybe I'll ask a clarification question for you. Was that a NAT test or an antigen test that came back positive?
So it was a NAT test that
Okay.
came back positive. Yeah.
So a NAT test that's positive within 90 days of a prior infection, there's some uncertainty about whether that represents a residual fragments of virus from before or not. Interestingly, I think there's some evidence to suggest that as you move out beyond a month or 2 months, a new antigen positive test, it might be more likely to represent a new infection because of what we know about the shedding of antigen versus the PCR fragments that are picked up. Having said that, the possibility of a reinfection within 90 days is there. It has been there as a possibility. We know that it probably does happen in some circumstances. Generally, people's immunity after infection is longer than that, generally speaking, but there are exceptions. And those are hard things for us to turn into policies and guidance. We try to do our best to reflect what's going to be best for the public.
Right. Thank you so much, Dr. McClung and Dr. Salerno. This was very informative. We are out of time at this time, and all the other questions that we have in the chats, we will follow up on them for our audience. But again, thank you so much, and I will turn it over to Llewellyn, who's our CEO for the UCA, for the final comments.
Thanks, Jasmeet. Just want to thank everybody for taking the time to be here. This is a members-only webinar, so I hope that makes you happy that you're a member. Thanks to Ren and Paul for sharing their expertise with us. We will send out the recording for this sometime in the next 24 hours, and you can share that with any other members that you know that are in your organization, et cetera. And then I have put Laurel Steimenoff's email into the chat if you have questions that occur to you after that we can facilitate getting an answer for you. It's lstoimenoff@ucaoa.org, but that's in the chat and we'll include it in the follow-up email as well. Thanks for being here and thanks for all you're doing out there. We appreciate you. Bye-bye.
Thank you so much. Bye.